Hi, I'm Henry Ginsberg. I'm the Irving Professor of Medicine at Columbia University Medical Center in New York City and co-founder and co-director of the PCSK9 Forum. And today I'd like to talk about a very complex and important problem, that is the cost of new treatments and the benefit that we can get from them, and what we call the cost of a quality life year for any treatment. There certainly has been a flurry of activity in this area, in this space, related to the new PCSK9 inhibitors, the monoclonal antibodies that are now available, alirocumab and evolocumab specifically, and with more to come. We know that there are individuals with high risk for cardiovascular events, particularly those who've already survived an event, those who survived an event and have diabetes mellitus, or multiple risk factors. We know from the trials looking at IVUS that individuals with LDL levels above 70 milligram per deciliter, or about 1.8 millimole per liter, have progression of their disease even with levels close or above those numbers, 70, 1.8. And lowering them further, at least in the IMPROVE-IT trial, reduced events. And in some of the IVUS trials where LDL levels were lower, they had regression, although limited data. So faced with those data and that information, what do we do and what do we think should be the appropriate approach to the use of the PCSK9 monoclonal antibodies, which on top of statins or ezetimibe will certainly lower LDL levels remarkably and lower them in many cases, all but the most severe FH patients, to below 70 milligrams per deciliter, to regions where we can hope for and hopefully prove that we get regression in almost all patients. And we have large clinical trials ongoing now with both of those drugs to see the improvement in outcomes, hard endpoints. So having said all that and looking at a very positive future, we have to look at the cost of this. And in recent publications, the estimated costs that would make these two drugs fall within the $100,000 per year for quality life year that has been decided upon as a reasonable cost, and that's another issue we can address, that their cost to the consumer or to the insurance company would be about $4,000 US per year. That is a number that is being proposed by the governments in Europe, where healthcare is controlled by the government. In the United States, the cost for each of those drugs is about 3 to 3.5 times that number, raising the issue of how costly should these new medications be to the overall cost of health, and what is the cost for a quality life year. I don't have the answer for how much anyone's life is worth, and I don't know exactly why $100,000 has been chosen as a reasonable gold standard for how much one's life is worth. But we do have to take into consideration that there are things that do save money. For instance, unfortunately, sudden death saves a lot of money to the healthcare system, and nobody wants that to be a positive outcome. There are the long-term effects that possibly and probably are not included in these models that produce and generate the cost of a quality life year. For instance, you survive a myocardial infarction, you have multiple risk factors, maybe you then get stented, maybe you then get coronary bypass surgery, and you do well for a number of years, but you go on to get heart failure because of the loss of myocardium. And once you have heart failure, I'm not sure how well those costs, which are incredibly high and accumulate over the next decade, where you're hospitalized numerous and increasing numbers of times and you're getting more and more medications, I'm not sure how much those costs are included in the present models. But beyond the cost, we have to deal with someone's individual risk for having another event with all its consequences. And that ranges from possibly about 2% per year up to 5 or 6% per year, depending on what's already happened to you. Obviously, if you've had an event, you're falling into the higher range. If you have diabetes or multiple risk factors, you're falling into that higher range of risk per year. Multiply that by 5 or 10 times and you see the overwhelming risk that you're going to have another event if you're in those categories. So we need to do more. And those are people on aspirin, ACE inhibitors, beta blockers, a statin, and most likely in the future ezetimibe as well. What's the next thing to do? Right now, we think it's PCSK9 inhibitors, but we have to prove that in the ongoing studies, and we still can't avoid taking the cost into account, the cost for the overall economy. The conundrum we face is that if 5% per year is an individual's risk, they still have a 95% chance of nothing happening to them in that time. Now, over 5 years, they're 25%. Over 10 years, they're 50% risk. Now there's 50-50. And when do you intervene? And we can't wait for that next event to occur, which will either kill the individual or lead to a much greater risk for heart failure down the road. And we really have to sort this out. I think the quality of life here analyses are important to make us think about this, but we also have to take into account all we know about cardiovascular disease, the toll it takes, and what we can do to reduce it. And lowering LDL is clearly a way to reduce that.